Ever felt overwhelmed trying to absorb a mountain of information? Especially when it's vital, maybe complex, even a little intimidating. Like understanding a new medical procedure or figuring out how to manage a chronic condition. It's a pretty common feeling, right?
Yeah.
Welcome to the Deep Dive. We're your shortcut to being truly well-informed. We dig into the sources, pull out the key insights, add some surprising facts, and, try to make it engaging. Today's deep dive is definitely custom-tailored for you, especially if you're navigating the demanding world of nursing education. We're aiming for those aha moments.
Yeah, today we're diving deep into patient education in nursing. It's really both an art and a science. Our main guide here is the Classic Fundamentals of Nursing, 11th edition, by Potter, Perry, Stockard, and Hall, a really foundational text. We're going to unpack how nurses can genuinely empower patients, turning that complex info into something practical, something actionable.
Okay, let's unpack this then. By the end of our chat, you won't just know what patient education is, you'll have a much better feel for how to actually apply it effectively in, any healthcare setting. We'll aim for clear explanations, practical takeaways, and really connect it all back to those NCLEX competencies.
So why is patient education just so critical? Well, think about it. Healthcare moves so fast now. You've got shorter hospital stays, more chronic illnesses popping up. Patient education isn't just like another task on the list. Sometimes it's the only thing that ensures the care actually sticks long term. It's basically the ultimate discharge plan, right? It determines if all that medical effort actually pays off down the road. Nurses are really stepping into this role, empowering patients to prevent disease, minimize disability, and just improve their overall wellness. It's about building health for the long haul.
That makes sense. It's proactive, not just reactive.
Exactly. And what's really interesting is that it's not just, good practice. It's a fundamental patient right. People have the right to be informed about risks, diagnoses, treatments, so they can make smart, informed decisions about their own bodies, their own health.
And that ties directly into patient-centered care, doesn't it? And things like QSEN.
Absolutely. It's a core part of patient-centered care and quality and safety, which QSEN is all about. And here's a bonus point that often gets overlooked. Good patient education, especially around prevention, can actually help reduce healthcare costs overall. Think lifestyle changes, avoiding chronic disease, it adds up.
Okay, so it's comprehensive. The book highlights three main purposes, which really shows how broad this nurse educator role is. Let's maybe think about a patient, let's call her Sarah. Say she's just been diagnosed with type 2 diabetes. How would these purposes apply? So first, there's health promotion and illness prevention. This is where the nurse guides Sarah toward healthier behaviors. For her, that means learning how diet and exercise can prevent those diabetes complications down the line. And success isn't just Sarah remembering facts, right? It's about her actually doing it, incorporating it into her daily life.
Right. It has to become part of her routine.
Then second is restoration of health. This is for patients recovering, needing info and skills to get back to health or maintain it. For Sarah, maybe this is learning how to administer her insulin correctly or monitor her blood sugar accurately.
And a really key point here is checking her readiness, her willingness to learn. Adjusting to a new diagnosis like diabetes, well, it can be tough. It takes time.
Yeah, and what about her family? They're involved too.
Hugely important. Families often need just as much education. Maybe on recognizing low blood sugar signs or even helping with diabetic-friendly meals. They're part of the care team.
Okay, and the third purpose. This one sounds maybe the most challenging. Coping with impaired functions. This is for patients who won't fully recover, right? Maybe they have permanent changes or even lower literacy skills, making it harder.
Exactly. They need new knowledge, new skills just for daily living. So if Sarah developed neuropathy, difficulty feeling her feet, we'd need to teach her really meticulous foot care to prevent serious wounds or infections.
So it's about finding a new normal, helping them achieve the best possible health within those limitations.
Precisely. It's about fostering a realistic level of independence and providing that crucial psychosocial support, often through educating the family as well. And, it's kind of wild how closely the teaching process mirrors basic communication.
How so?
Well, think sender, message, receiver, feedback. The nurse is the sender, the patient's the receiver, and that feedback loop, absolutely critical. You have to know if the message actually landed, if the patient understood. It closes the loop.
Makes sense. It's not just talking at someone.
Not at all. And this brings up a really crucial point. Nurses have a legal and ethical duty here. We have to provide education to all patients, Doesn't matter about gender, culture, age, literacy, everyone gets educated. Documents like the Patient Care Partnership from the AHA back in 2003, they really emphasize this right to make informed decisions. And the Joint Commission, TJC, they have their Speak Up campaign. You've probably heard of it.
Oh yeah, the Speak Up campaign. It gives patients really concrete advice, doesn't it?
It does, really practical stuff.
Like encouraging you, the patient, to speak up with questions or concerns. Don't be afraid to ask again if something's unclear. Pay attention to your care. Are you getting the right treatments, the right meds?
Yeah.
Educate yourself about your illness and the plan. Ask a trusted friend or family member to be your advocate. Know your new medicines, what they're for, potential side effects. Because med errors, sadly, do happen.
They're surprisingly common, yeah.
Also, research healthcare organizations if you can. And, maybe most importantly, participate in all decisions about your care. It's your health, after all.
That active participation is key. And this leads us right into a really vital evidence-based practice, the teach-back method.
Teach back. Okay, I've heard of this. It's more than just asking, do you understand?
Way more. It's actually a kind of paradigm shift. It puts the onus on us, the healthcare providers. If the patient can't teach it back, it means we probably didn't explain it clearly enough. We need to try again, maybe differently.
And there's evidence it works.
Oh yeah, solid evidence. One review showed something like a 45% drop in 30-day hospital readmissions when teach-back was used consistently. And for conditions like heart failure, it significantly boosts self-care and patient knowledge. It's powerful stuff.
So how does it work in practice? Instead of any questions, what do you say?
Use open-ended prompts. For Sarah, our patient with diabetes, you might say something like, just to be safe, I want to make sure we're on the same page. Could you tell me in your own words how you'll remember to take your insulin each day?
Or maybe, can you show me how you would inject your insulin at home? Like a demonstration.
Exactly. A return demonstration is perfect for skills. And the key is the approach. It has to be non-judgmental. If Sarah struggles, you don't make her feel bad. You say, okay, maybe I didn't explain that very well. Let me try explaining it a different way. You take ownership.
Got it. It's about checking your teaching, not testing the patient.
Precisely.
So, okay, we know why we teach and how to check understanding. But how do patients actually learn? What influences that?
Great question. The source material breaks learning down into three main areas, or domains. There's the cognitive domain, that's about understanding and thinking. Then the affective domain, dealing with feelings, attitudes, values. And finally, the psychomotor domain, which is all about physical skills.
Cognitive, affective, psychomotor.
And the most effective learning, especially for complex health stuff, it usually involves all three working together.
Right, it's holistic.
Exactly. Let's dig into cognitive learning first. This is about gaining information, developing intellectual abilities, thinking, knowing, understanding. You might remember Bloom's taxonomy from school. It's relevant here. Learning isn't just one thing, it progresses. You start with remembering basic facts, then understanding them, applying them, analyzing, evaluating, maybe even creating new ideas based on that knowledge.
So for Sarah, our diabetes patient.
For Sarah, cognitive learning is her understanding how her diet, her meds, her activity level all interact to affect her blood sugar. It's that intellectual grasp of the why and how. Each simpler level, like remembering what carbs are, is needed before she can analyze her meal choices.
Okay, that makes sense. Then what about effective learning? That was attitudes and feelings.
Right. This is about learning to express feelings, develop values, attitudes, beliefs, all geared towards improving health. It's often the trickiest domain. For Sarah, this is huge. It's not just knowing about diabetes, it's emotionally processing the diagnosis. It progresses too, from just passively receiving info to responding by asking questions, then valuing self-care, organizing her life around it, and finally characterizing where managing her health becomes part of her consistent value system.
So it's about accepting the diagnosis and integrating those changes into her life emotionally.
Exactly. It's the emotional and value-based side of learning.
And the third one was psychomotor learning, the skills part.
Yep. Physical skills. Developing manual dexterity, coordination. There's a hierarchy here, too. It goes from fundamental movements to perceiving cues to guided response, where you help them, then mechanism, getting proficient, complex overt response, skillful performance, adaptation, modifying for new situations, and even origination, creating new movement patterns.
Wow. Okay, so for Sarah, learning her insulin injections.
Perfect example. Fundamental is just holding the syringe. Perception is reading the dose correctly. Guided response is you showing her step by step. Mechanism is her doing it smoothly on her own. Adaptation might be figuring out how to inject if she's traveling. It's that hands-on skill development.
Got it. So to teach effectively across these domains, what basic principles do nurses need to keep in mind?
There are a few core factors that really influence how well someone learns. The big ones are motivation, readiness, ability, and the learning environment itself.
Okay, let's start with motivation. How do you motivate a patient?
Well, motivation is that internal drive, right? You can't just give it to someone, but you can help them find it. This is where techniques like motivational interviewing or MI are so powerful. It's patient-centered. You don't lecture. You help the patient explore their own reasons for making a change, resolving that internal ambivalence they might feel.
Ambivalence,
Yeah,
like wanting to manage diabetes but also finding it really hard.
exactly. MI helps them tip the balance towards change. And this connects really well to social learning theory and the concept of self-efficacy.
Self-efficacy. That's believing you can actually do something.
Precisely. A person's belief in their ability to succeed at a specific task. We can boost Sarah's self-efficacy for managing diabetes by, say, celebrating small successes, maybe connecting her with a support group, vicarious experience, giving her chances to practice skills until she masters them, in active mastery, and offering lots of encouragement, verbal persuasion.
So helping them believe I can do this.
That's the core of it. Another huge principle is understanding cultural factors. Culture deeply influences how people view health, illness, and learning. The ACCESS model is a great tool here. It's an acronym.
XCS, what does that stand for?
Assessment of lifestyle, beliefs, traditions. Communication, being aware of verbal and nonverbal cues. Cultural negotiation and compromise, acknowledging their culture and your own biases. Establishment of respect and rapport. Sensitivity to diverse needs. And safety, creating a culturally secure learning space.
So it's about really seeing the patient within their cultural context.
Yes, and building trust by showing you respect their perspective. It's not just nice to have, it directly impacts learning.
That leads nicely into active participation, doesn't it? Learning isn't passive.
Definitely not. Patients learn better when they're actively involved. So instead of just telling Sarah about food choices, maybe you have her practice reading food labels on items she actually eats, or plan a sample meal. Hands-on makes it stick.
Okay, what about readiness to learn? How do you know if a patient's actually ready?
That's crucial. And several things affect readiness. First, think about grief. Patients dealing with a new diagnosis or loss of function often go through stages: denial, anger, bargaining, resolution, acceptance. Where they are in that process massively impacts their ability to learn.
So if Sarah is still in denial about her diabetes,
You probably wouldn't overload her with complex long-term management strategies right then. You'd offer support, maybe focus on immediate needs, keep explanations simple and present-focused. You tailor your approach to their emotional state.
what else affects readiness?
Their physical health status is a big one. Someone acutely ill. Their focus is survival, comfort, not the time for detailed teaching. Someone in rehab, though, might be very motivated to learn self-care skills.
And their mental state, like if they're anxious or in pain?
Absolutely. That's the attentional set. Can they actually focus? Pain, extreme anxiety, confusion, these all block learning. You have to address comfort first. Mild anxiety might actually help focus, but high anxiety shuts learning down.
Makes sense. Prioritize the person before the teaching plan.
Always. Then there's the patient's actual ability to learn. This involves their developmental stage and their cognitive and physical capabilities.
So developmental capability, like teaching kids versus adults.
Exactly. With kids, you use concrete examples, visuals, play therapy, shorter sessions. Adults, they're usually self-directed, want to know why they need to learn something, and draw on past experiences. You relate the learning to their life, their problems.
And health literacy, we touched on that earlier.
Huge factor. Remember, many adults struggle with health information, especially if it's full of jargon. Materials often need to be at a fifth-grade reading level.
And people might hide it if they have trouble reading.
Very common due to shame or embarrassment. So nurses need sensitive ways to assess. Maybe ask them to read a prescription label back to you or explain a concept in their own words. Using simple language, avoiding jargon, using visuals, all crucial. We also need to consider learning disabilities, sensory issues like poor vision or hearing loss, even ADHD affecting focus.
And physical capability.
Yeah.
For the skills part.
Right. For psychomotor skills, does the patient have the necessary strength? Coordination. Good enough eyesight. Can Sarah physically hold the insulin pen and see the dose window clearly? Pain, fatigue, nausea. These physical symptoms will also limit their ability to practice skills, assess their energy level. Maybe shorter, more frequent practice sessions are better.
Okay, one last factor. The learning environment.
Yeah, seems basic, but it matters. Ideally, it's quiet, private, well-lit, comfortable temperature, appropriate furniture.
Hard to find in a busy hospital sometimes.
It can be. Even just pulling the bedside curtain can help create a sense of privacy and reduce distractions.
Mhm.
For groups, make sure everyone can see and hear comfortably.
It's really clear that patient education is way more than just giving out pamphlets. It requires real critical thinking, real clinical judgment.
Absolutely. Nurses use that judgment, constantly figuring out what the patient needs to learn, when is the best time to teach, which resources or methods will work best for this specific patient.
And you mentioned earlier it parallels the nursing process.
It does, very closely. Think about it. Assessment. Nursing process gathers broad patient data. Teaching assessment zooms in on learning needs, motivation, ability, literacy, resources.
Okay.
Diagnosis. Nursing diagnosis might be risk for unstable blood glucose. A related teaching diagnosis could be lack of knowledge regarding insulin administration. Or maybe the nursing diagnosis is acute pain, which becomes a barrier you delay touching until pain is managed.
Right.
Planning and outcomes. Nursing plan sets broad goals. Teaching plan sets specific, measurable learning objectives, like Sarah will demonstrate correct insulin injection technique by end of shift.
Very specific.
Implementation. Nursing implements the overall care plan. Teaching implements the specific educational strategies you chose.
And evaluation.
Both evaluate if outcomes were met. But teaching evaluation specifically measures if those learning objectives were achieved. Did Sarah actually demonstrate the technique correctly?
So how do nurses prioritize what to teach first, especially with limited time?
Good question. You use clinical judgment. What does the patient need to know right now for safety? For Sarah, learning how to recognize and treat low blood sugar is probably more urgent than long-term dietary changes. Safety first.
And timing. You mentioned shorter sessions.
Yeah, even though hospital stays are short, evidence suggests frequent, shorter sessions, maybe 10-15 minutes, often lead to better retention than one long, overwhelming session. You have to be efficient and focused.
Okay, let's talk implementation. Putting the teaching plan into action. You said active engagement is key.
Absolutely. Get the patient involved. Use multiple senses, show them, tell them, let them handle equipment, use videos, maybe even role-play scenarios.
And always manage symptoms first. Pain, anxiety.
Critical first step. If they're uncomfortable or highly anxious, they simply won't be able to learn effectively. Address that first.
And build on what they already know.
Always. Start where the patient is. Find out their existing knowledge, their skills, their attitudes, and tailor your teaching from there. Don't assume they know nothing, but also don't assume they know everything.
The book mentions different teaching approaches, like telling, participating.
Right. There are different styles depending on the situation. Telling is very direct, used when time is limited, like prepping someone for an emergency procedure. Not much interaction. Participating is more collaborative. Nurse and patient set goals together, discuss content. Good for things like Sarah learning about diabetes management over time. Lots of discussion and feedback.
Okay.
Entrusting is when the patient takes the lead in self-care and the nurse provides support and monitors progress, like Sarah managing her insulin independently after she's confident. And reinforcing is simply using positive feedback, a smile, praise to strengthen desired behaviors, like complimenting Sarah on her improving injection technique.
Makes sense. What about specific methods? How do you actually deliver the information?
Lots of tools in the toolkit. Verbal one-on-one discussion is probably the most common. Informal allows for personalization and immediate questions. Models like the EDUCATE acronym can help structure it effectively. Yeah, enhance comprehension, deliver patient-centered info, understand the learner, communicate clearly, address health literacy, and measure outcomes. Just a helpful framework.
Okay, what else?
Group instruction can be great, economical, plus patients learn from each other. Best in smaller groups, maybe 6 people or fewer, so everyone can participate.
Preparatory instruction. This is about reducing anxiety before tests or procedures, right?
Exactly. Explain what they'll see, hear, feel, smell, describe the sensations and why they happen. You'll feel a sticking sensation when the needle goes in. You can also use reappraisal. Frame it positively, like, this IV will provide the fluids your body needs right now.
How about skills, like Sarah's injections?
That's where demonstrations shine. Perfect for psychomotor skills. Key things.
Yeah.
Make sure the patient can see clearly, have equipment organized, go step by step slowly, explain the why behind each step, and critically get that return demonstration. Have them show you.
The teach back for skills.
Essentially, yes. You need to see them do it.
What about analogies?
Analogies are great for making complex ideas relatable. like explaining blood pressure, using the image of water flowing through a hose, connects the new idea to something familiar.
And role-playing.
Good for practicing communication or responses. Maybe Sarah practices how she'll explain her dietary needs at a family dinner. Or a parent practices responding to a child's tantrum related to a medical procedure.
And simulation.
That's more for complex problem solving. Maybe having heart patients plan a heart-healthy meal from a menu, applying multiple principles they've learned.
It seems crucial to adapt these methods for patients with special needs.
Absolutely essential. For patients with illiteracy or learning disabilities, create a shame-free zone, use very simple terms, keep sessions short, rely heavily on visuals and demonstration, relate info to their personal experience, and always get that return demonstration.
For sensory deficits, like vision or hearing loss.
Use appropriate tools, sign language interpreters, clear written materials in large print, usually 14-point font or bigger, high contrast like black on white or yellow audio recordings. Make sure lighting is good. Reduce glare.
Cultural diversity.
Back to respecting beliefs. Use interpreters when needed, professional ones, not usually family members. Be aware of potential family dynamics or conflicts. Tailor your approach. Culturally congruent teaching gets better results.
And children versus older adults.
Adapt to their developmental level. For kids, play, simple explanations involve parents. For older adults, ensure comfort, minimize glare, speak slowly and clearly in a lower pitch. Hearing loss often affects higher frequencies first. Make sure they have glasses or hearing aids on. Keep sessions short due to potential fatigue. Allow more time for processing and build on their lifetime of experience. Using black 14-point print on non-glossy white paper is often recommended, and avoid blues and greens if possible, as they can be harder to distinguish.
And what about general teaching tools? Beyond demonstrations.
Well, there are written materials like pamphlets or handouts again, keeping literacy levels in mind. Diagrams, charts, pictures are great visual aids. Physical objects like showing Sarah the actual insulin pen, audio-visual materials, videos, apps.
Lots of options.
Yeah, the key is selecting tools that fit the patient's learning style, needs, and abilities. And if you recommend websites, guide them to reliable sources, CDC, American Heart Association, established patient advocacy groups. Not just Dr. Google.
Right. Okay, so after all the teaching, we need to evaluate, did it actually work?
Exactly. An evaluation starts by seeing it through the patient's eyes. Ask them, were your expectations met? Do you feel more confident now? Did we cover what you felt was important? Their perspective matters hugely.
Then you measure the outcomes more objectively.
Right. You measure if those specific learning objectives you set were actually met. Observe them performing the skill. Ask targeted questions. Okay, tell me 3 signs of low blood sugar we discussed. Or, show me how you would use your inhaler.
And this brings us back again to teach back.
It really is the gold standard for evaluation, especially for cognitive understanding. That closed loop check. Ask them to explain it back in their own words or show you the skill.
More examples.
We've gone over a lot about your new medication. Can you tell me the main side effects we need to watch out for? Or show me how you would check your blood sugar level using this monitor.
And if they struggle?
It's your cue to reteach.
Okay.
Let's go over that part again. Maybe I can explain it differently. Take responsibility for clarity.
And finally, documentation. Always important in nursing.
Absolutely. Documenting what you taught, how the patient responded, whether they met the objectives, and any plans for reinforcement. It's a legal requirement, ensures continuity of care, helps with quality improvement, and TJC looks for it. It closes the loop formally.
Wow. This deep dive really highlights just how central patient education is. It's not an add-on. It's fundamental to empowering patients and keeping them safe.
It really is. And mastering patient education, I think it's a true hallmark of an excellent patient-centered nurse. It pulls together assessment, communication, critical thinking, compassion, everything.
It's about truly partnering with patients.
Yeah. So maybe a final thought for our listeners, especially those heading into practice. As you step into your nursing role, how will you move beyond just giving information? How will you genuinely partner with each patient, ensuring they feel heard, understood, capable, and truly empowered to take the reins of their own health?
That's a great question to reflect on. Thank you so much for joining us on this deep dive into such a vital part of nursing. We're really glad to have you here as part of the Deep Dive Learning community.